Hi everyone, this is Professor Sujata Sharma, and today we're going to dive into a very exciting topic, and that is immune checkpoint inhibitors, a promising and a new therapy for cancer patients. Now, just imagine that if instead of traditional therapies like radiation and chemotherapy, you could actually somehow induce your own immune system to attack and kill tumor cells. Wouldn't that be completely path breaking? And that's what we're going to talk about. And we have with us Dr. Alma Vikram. Welcome, Dr. Alma.
Thank you very much. It is an honor. I would like to share my screen.
Over to you.
So I would like to talk about how a new kind of therapy has completely revolutionized cancer treatment, and that is the immune checkpoint inhibitors. So I would like to firstly state that most of us are aware that cancer treatment with anti-cancer drugs is known to be highly toxic, and it is understood that that is because the anti-cancer drugs, they tend to also attack the healthy cells in virtually all parts of the body. However, what most people are unaware of is that the cancer cells carry with them certain peculiarities, which can be meticulously exploited so as to create more advanced and more specific kinds of treatment. And immune checkpoint inhibitors are just one of them. So I would like to take you back to the year 2011 when Yervoy, which is the trade name for the drug ipilimumab, which is the first immune checkpoint inhibitor which was approved by the FDA, was used in the treatment of a type of tumor which was notoriously known for its extremely grim outlook. So here we can see that there is a survival time analysis for uh, a subset of patients who were treated with this new drug, which is ipilimumab, which is represented by the blue line. Now, the other subset of patients who were treated with the conventional treatment of dacarbazine is represented by the yellow line. And here it is greatly appreciable that the overall survival estimate of those patients who were treated with the new drug is extremely different. It is much better. So this highlights the advancement in cancer treatment with the help of these immune checkpoint inhibitors. But this was just the beginning, as there have been various FDA approvals through the years. So it started with ipilimumab, and then came 2014, where we saw the development of pembrolizumab and nivolumab. So ipilimumab, as we've seen, is used in the treatment of metastatic melanoma, and pembrolizumab is used in the treatment of a wide variety of cancers, which include non-small cell lung cancer, type of lung cancer, head and neck cancer, Hodgkin's lymphoma, and even recently it is used for uterine cancer. Nivolumab is a drug which is used in conjunction with ipilimumab for metastatic melanoma. Apart from that, it is also used in Hodgkin's lymphoma. Then 2016 saw the approval of atezolizumab, which is used for a peculiar type of bladder cancer known as urothelial carcinoma. Again, avelumab in 2017 was approved for the use of urothelial carcinoma, as well as a type of skin cancer known as Merkel cell carcinoma. Then durvalumab is used for the treatment of non-small cell lung cancer, just like pembrolizumab. And over the years, there have been more and more FDA approvals coming up. So the future looks bright. Now, here we're going to talk more in depth about the hallmarks of the cancer cells, as these are the important keys which help us come up with more specific and less toxic treatment options. So, what is it in the cancer cells which differentiates them from the normal cells? Firstly, they're able to sustain the proliferative signaling, which helps them keep on growing. Apart from that, they're able to evade the growth suppressors, which again leads to continuous growth. Apart from that, they're also able to avoid immune destruction. They can enable replicative immortality. They can promote inflammation. They're able to invade and metastatize, which means that they're able to spread to other organs. And since they are growing in large numbers, their demands are never ending, which is why they are able to induce the formation of new blood vessels known as angiogenesis. They are also able to create a phenomenon of genomic instability and mutation. They are able to resist cell death by various mechanisms, and they can also deregulate the cellular energetics. Moving on, now we should talk about how the link between oncology and immunology, such contrasting fields, came to be established. So, firstly, we know that the immune system is likened to like an army which can fight against the foreign substances which enter the body. So, by that principle, we can understand that the tumor cells have certain peculiarities which enable the immune system to act against these cells and keep them at bay. Now, this is a concept which was proposed by Thomas and Burnett. It is known as immune surveillance. However, if that were the case, and if the immune system were equipped enough to handle all kinds of tumors, then why would cancers arise at the first place? So, this means that there are certain ways where the cancer cells have been able to outsmart the immune system. So, I would like to explain that with the help of this figure. Now, here we can appreciate that there is a normal healthy cell which, under the influence of certain triggers like a chemical carcinogen, radiation, genetic mutation, or a viral infection, gets transformed into a cancer cell or a neoplastic cell. Now, this cancer cell can either revert back to its normal state via certain mechanisms like repair of the DNA, cell death, or cellular aging. However, in some cases, this does not happen. Now, there are two potential outcomes. When confronted with the immune system, either immune surveillance will come into play and ultimately lead to tumor rejection, or the cancer cells will outsmart the immune system by another phenomenon known as tumor editing or immunoediting, in which the tumor cells have certain ways of modifying the action of the immune system and ultimately evading the immune system's attack on the tumors. So finally, they escape the immune surveillance. Now, here we talk about immune checkpoints, which are known as the gatekeepers, which are the central topic of discussion for this presentation. So, immune checkpoints are essentially regulators of the immune system, which act to prevent the indiscriminate attack on the cells by the immune system. So, since they are regulators, we know that they can be either stimulatory or inhibitory. The stimulatory checkpoints will act to enhance immune action. So these include CD27, CD28, CD40 to name a few. But here we're going to focus more on the inhibitory checkpoints, as these are the target of the cancer cells and the recent drugs that have come up. So the inhibitory immune checkpoints, what they do is that they will inhibit the action of the immune cells so as to stop the replication of the cancer cells. Right. So here we have PD1, which is also known as programmed death 1, which is a type of receptor present on the T cells. Then there is CTLA4, which is cytotoxic T cell cytotoxic T lymphocyte associated antigen 4. Apart from that, there are others like LAG3, TIM3, VISTA, NOX2, and many others which are coming up as emerging targets for newer drugs. Now, I would like to first shed some light on CTLA4 pathway. So CTLA4, like I've already discussed, is the cytotoxic T lymphocyte associated antigen 4. Now, this is present on the T cell, but this is an inhibitory checkpoint. So, which means that there is also a stimulatory checkpoint, which is the CD28. Now, here we can see in this figure, there is an antigen presenting cell, which presents to the T cell an antigen for the T cell receptor, the TCR, to recognize. And MHC is the major histocompatibility uh, uh, protein. So here the thing is that if the CD86 receptor, the interaction of this receptor will determine the ultimate fate of the T cell. If it interacts with the CTLA4 pathway, with the CTLA4 receptor, then that would lead to the inhibition of T cell action. However, if it activates the activator, if it acts with the activator, that would lead to stimulation of the T cell. So we can understand that the cancer cells will act on the CTLA4. They will stimulate the CTLA4 interaction with the CD86 protein so as to inhibit the action of the T cell on the tumor cell, which would lead to greater replication of the tumor cells. So here we would target the CTLA4 protein by certain drugs, which are nothing but monoclonal antibodies, which means that they act against the CTLA4. And these include ipilimumab, which was the first FDA-approved drug against metastatic melanoma, as we've already discussed, and tremelimumab. Now, the other important pathway that we have to discuss is the PD1, PDL1 pathway. So PD1, as I've already stated, is the programmed death receptor 1. This is present on the T cell and it interacts with its respective ligand, which is present on the tumor cell, which is the PDL1 ligand. So programmed death ligand 1. Now, these two will act together to, when they interact with each other, that would lead to suppression of the T cell, which is what the cancer cells would promote. However, the target now becomes that we have to inactivate either the PD-1 or its respective ligand. So, anti-PD-1 drugs include pembrolizumab and nivolumab. Anti-PD-L1 drugs include atezolizumab, avelizumab, and durvalumab. Now, the question is, this revolution of immune checkpoint inhibitors, is it really too good to be true? We've discussed the great breakthrough that it has been, but does it have any limitations? And being a new drug in the market, definitely the adverse effects are relatively less studied. Moreover, we have to understand that while it does not attack the normal cells, it does have an action on the immune system. It does tend to excessively activate the immune system. So there is a spectrum of adverse effects which it leads to, which is known as immune related adverse events. Now, these are highly non-specific. They can range from colitis, which is inflammation of the bowel, to hepatitis, which is inflammation of the liver, to acting on hormones such as the thyroid hormone, leading to hypothyroidism. It can also act on the steroid hormone, which is also known as the adrenocorticotrophic hormone. Apart from that, it can also lead to myocarditis where it involves the heart. So the key is that you have to have a very high index of suspicion when you come across a case of these kind of adverse events. Apart from that, it also has certain non-specific adverse effects like nausea, vomiting, diarrhea, which differ between the various drugs. And the other thing which is too obvious to be mentioned is the relatively higher cost. These being the newer drugs, they come with a much higher cost. So we have to consider both the limitations and the advantages and then weigh each other. So I would like to thank you for the patient listening.
That's so informative, and I'm full of hope that even though, as you mentioned, there are a couple of limitations, yet I'm sure, as with any new therapy, we are going to be able to overcome as the time goes. And definitely, the future seems to be very bright for cancer patients. Thank you so much again for joining us, for giving us such wonderful information, simplifying it, and of course, explaining everything in great detail. Thank you very
Thank
much.
you.